sorry, just give me 1 second. So hi everyone, my name's Alyssa. I'll be talking about neonatology and a little bit about infectious diseases today. And I've also just put my email there. So if you guys have any questions about any of the topics today or anything else I can answer, I'm happy to get any emails regarding that. I'm also one of the co-chairs for Paeds, so I just wanted to flag that we have quite a couple of resources available. So these are the summary sheets about the topics that I'll be going through in this lecture. And there are also heaps of MCQs, past lectures, RCs, exams, as well as a buzzword document. So check those out. And then we also have a couple of events coming up. So we have our RC night this Thursday, and we'll be going through 8 stems and sign up close on Tuesday, so just make sure you sign up as soon as you can if you're keen. And then the last thing is we are also running our elections currently. I've been on Paeds for 3 years, and it's always been a really fun and wholesome committee. So if you like kids or you want to just be part of a really fun committee, I would really encourage you to apply. And without further ado, we'll just get started with the lecture. So in terms of today's lecture, so it's pretty full on with the number of topics that I'll be covering, and most of them are R1 and R2. So in terms of any questions you may have, I'll try to get to them, but if you want to just put them publicly in the chat for questions, then Liv and Maddie and Lauren can also get to it. And otherwise I'll just get to them at the end of the lecture. And then I'll be touching a little bit about infectious diseases, just mainly the leftover topics that weren't covered by other lectures. And then everything else is just going to be covered in other lectures. Cool, so we'll get started on neonatology. And this is just a reference slide for you guys to come back to at your own time. But the most important thing to take away from this slide is these 3 definitions that I'm sure we're all very familiar with. The first thing is that a neonate is referring to a baby in the first 28 days of life. And then small for gestational age is referring to a baby that's less than 10th centile compared to babies in their gestational age. And then 37 weeks is obviously the cutoff for a preterm infant. And in terms of neonatology, I think it's best to learn it in terms of a timeline. So you want to think about the different periods of neonatology. So you have before birth, at birth, in the first week of birth, and then in the 2 to 4 weeks after birth. And that's sort of when you get different issues based on different physiology. And I'll also be going through the lecture in this order, and then prematurity can obviously affect the baby throughout that entire neonate period. Cool, so we'll start right at the start of the timeline with neonatal resuscitation. And we'll start with a couple of questions. So a well-grown baby born at 39 weeks with venous delivery after a non-reassuring CTG during the 2nd stage of labor. At delivery, he is blue, amnemic, and floppy. What is the first thing that you're going to do for this baby? And I'll also just say that all the questions in this lecture have come out in previous exams before, so I've just tried to keep them as exam focused as possible. Perfect. So you guys are just all rolling in with the answers really quickly. So the answer is G. And so you always want to start off with stimulating the baby. And we'll talk about why. Now you've stimulated the baby is still blue and floppy. The heart rate is now 75. What is the next thing you're going to do for this baby? Yeah. Perfect. So most of you are saying H, which is the right answer. And I think there are a couple of answers with I, and we'll just talk about why you want to do positive pressure ventilation at this point. And the last part of the question is, it is 1 minute later, you've been giving positive pressure ventilation, but the heart rate has now dropped to 55. And what would you do now? Yeah, beautiful. Okay, a couple of varying answers again, but most of you have answered D. So we'll go through why the answers were like so. So neonatal resuscitation, so it's really about learning the flow chart. So in the first 10 minutes of life of the baby, it's a really, really crucial period. And Anisha sort of touched on the transition that a baby has to go through at birth when they're sort of from mom's uterus to the real world where they have to start breathing in room air. So it's a huge transition they have to go through, and basically anyone who can't make that transition independently needs neonatal resuscitation. And neonatal resuscitation basically comprises all of these measures. So it comprises stimulation, respiratory support, and chest compressions. And depending on how they are clinically and where they are in the flow chart, you want to give different forms of support. So we'll go through the flow chart. So the first thing at the top of the flow chart is assessment. And there's a really common misconception that you use the APGAR score to decide if a baby needs neonatal resuscitation, and that's not true. So an APGAR is basically taken at 1 and 5 minutes, and then every 5 minutes if the APGAR is less than 7. But the reason that's not for neonatal resuscitation is because the APGAR is calculated at 1 minute, and neonatal resuscitation should have been initiated way before that if they do need resuscitation. So in terms of resuscitation, the assessment is largely the same as what you have in your APGAR, but it's the 3 main things that you have to remember. So is the baby term? Is the baby crying? And or is the baby breathing? And if they're crying, they're breathing. And does the baby have good tone, or they're really floppy? And if you've answered no to any of these questions, then the baby needs neonatal resuscitation, and you move on to the next part of the flow chart, which is basically telling you to stimulate the baby. And that's basically what you do for babies who need resuscitation, and most of them are going to be able to breathe independently just with stimulation. So what you want to do is basically to rub them quite hard, either on the chest or in the back. And sometimes you can do it with the towel and simultaneously dry them. And often that is all they need. But in the same little bubble, you can also start with your ABC and your resuscitation, similar to what you do for an adult. So you start with airways, and with babies, you just want to maintain a neutral position. So you don't want to do any like head tilt chin lift like you do in an adult. And you can also suction if needed. And then we move on to the next part of the flow chart, which is basically your B and ABC, so breathing. And with breathing, there are 2 options that you can do here, and it's mainly based on the baby's heart rate. So just remembering the burst rate of 100. So if the baby is apneic or not breathing and their heart rate is less than 100, then you want to give positive pressure ventilation, which is sort of a more, I guess, invasive form of support. And then if the baby is spontaneously breathing, but they're just not breathing very well, and you just want to give the baby a little push, and most of the time the baby's heart rate is more than 100, then you want to give CPAP. And at the same time, you want to put a pulse oximeter on. So another misconception is that you give baby oxygen straight away if they're hypoxic. But in terms of babies, you just want to make sure they're actually breathing before you actually give them oxygen. Otherwise, you're just sort of blowing oxygen into a baby that doesn't breathe, and that's not going to help with their steps. And then you have this little bubble down here, which is basically your SpO2 targets. And it's come out in exams before, like at 3 minutes, what targets do you aim for? And this is when you give them oxygen if they're below targets. I wouldn't recommend memorizing the targets just because it's just very low yield, but just knowing that it sort of starts at 60% at 1 minute and ends at 85% at 10 minutes, and then it sort of stays the same from 5 to 10 minutes. You can sort of work it out in your exam what targets you're roughly aiming for. And for anyone wondering, this is just extra information, but the difference between PPV and CPAP is basically that PPV use 2 types of pressures. They use PIP and PEEP, and it literally moves air in and out of the baby's lungs, so it helps the baby to breathe. Whereas CPAP provides just 1 level of pressure, and it just maintains the lungs as an open airway and keeps the alveoli open. And then the last part of the flow chart is basically C in resuscitation. So we have circulation, and basically, again, all about heart rate. So this time, just remembering a heart rate of 60. So if the baby's heart rate is 60 to 100, that's when you just assume that circulation is intact, and you just want to continue optimizing A and B. And I think that was one of the options. I think it was like I in the option where you continue optimizing airway and breathing. But if the heart rate is less than 60, that's when you want to start chest compressions. And you do this with a 3-to-1 ratio in babies, and with 100% oxygen if you start chest compressions. And then the last thing is if the heart rate is consistently below 60, even after you've started chest compressions, then you want to consider IV adrenaline. So that's neonatal resuscitation in a nutshell. Things to remember is always dry the baby first, always stimulate first, and then remembering the 2 heart rate cutoffs, so 100 and 60. So hopefully that helps a little bit with your exams. We'll go through respiratory distress in a newborn. And with respiratory distress, so it's mainly respiratory distress sort of in the hours after birth rather than in the minutes after birth. And that's sort of a little bit different from neonatal resuscitation. So again, a couple of questions. A baby is born at 30 weeks following the spontaneous onset of labor. Delivery is straightforward, but at 2 hours, he's noted to be grunting with increased work of breathing and reduced oxygen saturation. Chest X-ray is shown below. And what do we think it is? And hopefully, Chelsea, I've answered your question about CPAP versus PPV. Beautiful. So we have respiratory distress syndrome, and it's just very buzzwordy. You have a preterm infant. And then a baby is born by elective C-section at 38 weeks. He is quiet at birth, requiring stimulation to establish respiration. Following transfer, and you guys are all already answering the question. He is tachypnic. Yeah, perfect. Super buzzwordy. So you have C-section and tachypnea. So respiratory distress in a newborn, we have a whole bunch of different conditions that we want to consider, but the presentation is going to be pretty much similar. So how to differentiate them is based on the risk factors, and we'll talk about that. So anything that shows increased work of breathing, you want to think about these conditions. So the first thing, so the two most important things to know is respiratory distress syndrome and tachypnea, transient tachypnea of the newborn. So we'll go through RDS first. So RDS is due to surfactant deficiency in a preterm infant. And the reason for that is surfactant is mainly produced in the later gestation, and therefore preterm infants have surfactant deficiency. And as we know from like year 1 and 2 physiology, surfactant is really important to keep the alveoli open. So when the preterm infant is deficient in that, they basically have collapsed alveoli or alveolar atelectasis, and that's what you can see on the chest X-ray with your ground glass appearance. So you can kind of see that it's sort of a bit sandy and supposedly looks like ground glass. And it's basically reflecting the alveolar atelectasis. In terms of prevention, that's why we give antenatal steroids if they're preemies, just so we can help with lung maturation. And in terms of management, you can actually give surfactant exogenously when the baby is born via an endotracheal tube. So it's sort of like a tube, and you like spray the surfactant mist. Often they require respiratory support in the NICU, so they might require CPAP, PPV, or intubation. And then you have transient tachypnea of the newborn, or TTN, and that's mainly due to C-section. And the reason for that is that these babies basically have delayed lung liquid clearance. So when Bob is in uterus, they're basically surrounded by amniotic fluid, and therefore their lungs are filled with liquid. So any baby who is born needs to be able to clear that liquid quite quickly to be able to breathe. And babies with C-section fail to do that effectively, and that's because a lot of the mechanisms either happen during labor or during vaginal delivery. So cold C-sections, the C-section without labor, is sort of the highest risk for TTN. In terms of chest X-ray, you get this perihilar streaking in a sunburst pattern as your buzzword. And so I don't know if you can see sort of like the lines that is meant to look like sun rays. And in terms of management, it's just supportive. It's actually not something that you'd be massively worried about. You just want to observe them, and it should resolve on its own. Whereas RDS is something that often may require a NICU admission, so it's something a little bit more severe. Great. And then we have a spot diagnosis. So either you know this or you don't. If anyone wants to give it a go. Perfect. So, yeah, so this is A, which is congenital diaphragmatic hernia. So this is basically a scaphoid abdomen. So last two things you need to know with respiratory distress. First one is meconium aspiration syndrome. Very much in the name. So just basically when a baby aspirates meconium while in uterus, and they're basically born sort of covered in meconium. And in terms of the risk factors, most common in postpartum infants, and basically postpartum infants more than 42 weeks have very matured gut systems, and so they're more likely to pass meconium earlier on in uterus. And so in terms of chest X-ray, you get patchy opacification, and it's sort of a bit more patchy compared to RDS, which is a bit more fine in terms of the ground glass appearance. And it basically reflects areas of atelectasis and hyperinflation. And also just, I guess, highlighting that meconium basically irritates the lungs. the chemicals in meconium irritates the lungs, so it's not an infection. But in terms of management, it's supportive, and then you want to give antibiotics until you can rule out an infection. And then congenital diaphragmatic hernia, you don't have to know too much about it. Just basically know it's basically a congenital defect in the diaphragm that basically causes the bowels to herniate into the thorax. And so that's what you see on your chest x-ray. And then the other buzzword is obviously a scaphoid abdomen that you can see in this baby here. And management is surgical. Cool, and then we'll cruise on right through to birth injuries. And feel free to let me know if I'm going too quickly as well. But birth injuries, we had this question come out in our ONG exam a couple of years ago. So a baby is born at 40 weeks with vacuum extraction. Upon conducting a neonatal check, the baby is found to have the following, and he is well. What is the most likely diagnosis? Beautiful, oh my goodness. Okay, you guys are doing incredible. So Chignon is the answer that I had no idea about when I was doing the exam, but just guessed it. So birth injuries, you just basically need to know the location, which really is going to tell you about the symptoms and the management, like if it's important or not. So in terms of location, so if you just look at this diagram we have at the top, sorry, I'm just going to adjust my screen. So a caput secundum is basically a bruise that's in the most superficial layer, basically in the scalp or in the skin. And it's just like a swelling in the subcutaneous tissue. And the way I remember it is basically like put sounds a bit like bruise. So just remembering that it's more superficial. And then you have your cephalohematoma, which is essentially you can think of it as in the bone. So it's subperiosteal, which is this black line here. And because it's bound by the periosteum of the bone, it doesn't cross suture lines, and it's also going to limit the blood loss. And so it's not going to be a massive blood loss. Whereas the subgaleal hemorrhage is above the aponeurosis, and therefore, above the periosteum and below the aponeurosis. And basically it's not bound by the periosteum, and you can kind of think of it as like around the brain, although technically it's above the bone. But basically because it's not bound by the periosteum, it bleeds sort of endlessly, and that's why it's fatal and really important to flag really soon. So just think of it as caput in the skin, cephalohematoma in the bone, therefore it's bound, and then subgaleal around the brain, although technically not really. And then in terms of causes, basically they all have the same causes, like anything that basically compresses the head can cause any of these injuries, but specifically buzzwords. So Chignon is specifically due to a vacuum extraction, and you can see in the previous slide, the baby had like literally like a mushroom cap that looked like they had a vacuum on, but they're well. And then cephalohematoma, forceps, and then subgaleal hemorrhage, mainly due to vacuum. And that's why when we counsel mom about instrumental delivery, we always say that vacuum is better for mom, but worse for bub. And then I guess something to flag as well, the difference between a Chignon and a subgaleal is firstly, they're going to be hemodynamically unstable in a subgaleal. But secondly, a subgaleal has to be diagnosed based on palpation rather than visualization. Cool, and then we go on to suture lines. So again, periosteum bound cephalohematoma, therefore it's not going to cross suture lines, but everything else it is. And in terms of findings, caput is literally like a bruise, so it's just going to be a bit swollen. Cephalohematoma, you have distinct margins because it doesn't cross the suture lines. And subgaleal, the buzzword is boggy, so it's going to be boggy and it's obviously going to cross suture lines. And in terms of management, the main thing to note is that subgaleal, you just want to escalate that really, really quickly. But with any like doubt of whether you have a cephalohematoma subgaleal, you always do like an ultrasound just to make sure that it is not a subgaleal. So that is birth injuries in a nutshell. Don't have to know it in too much detail. I think it's an R2. But we'll move right on to neonatal sepsis. The neonatal sepsis is something that hasn't really come out in exams, to be honest, but it's always something that people want to know about. So main thing to know about neonatal sepsis is the etiology. So early onset versus late onset, and then the management or the antibiotics, as well as the septic screen. So early versus late onset is pretty self-explanatory, and you can kind of work through it in your head. Like you don't really have to memorize it. So early onset is less than 48 hours. So you're thinking of a baby that's literally septic at birth or quite soon after birth. So mostly due to vertical transmission. So mostly due to mom, like anything. So all your ONG risk factors. So like maternal fever, chorioamnionitis, GBS bacteriuria. Can't really pronounce that, but we had this in Aussies as well a couple of years back. Yeah, just remembering that this is GBS in the urine and not the vaginal canal, because I kept saying you have GBS in your vaginal canal, and the examiner was just laughing at me the whole time. And then in terms of causative organisms, so GBS is the big one, as well as E. coli. So anything that you can think of that's in the vaginal canal, yeah, you can think of that as causing sepsis. And then other thing is obesity. Yeah, and then preterm infants, basically they have a lower immune system or a weaker immune system, and therefore it can also be a risk factor. And then late onset is basically hospital-acquired infections. So again, similar to an adult, thinking of all your staph infections, and as well as the prolonged NICU stay, foreign bodies, and anatomical malformations like a neurotube defect can also be a risk factor. Presentation, super non-specific. So with babies, they might be lethargic, jaundice, irritable, and then top to toe, you have seizures, which is very rare, but if they are there, you're really highly suspicious that they have an infection. And then in terms of cardiovascular, basically circulatory failure, respiratory, or your increased work of breathing that we just went through. And then they might also have poor feeding, loose stools, vomiting, and red flags. Basically, if mom is concerned or if parents are concerned, you should be concerned as well, but very non-specific, and you can kind of tell if the baby is unwell. And then in terms of investigation, so we want to go through our full septic screen, and most importantly, your FTE, CRP, and ESR, as well as your blood cultures. And then you also do something called a well-being screen, because you can get electrolyte imbalances as well as hypo or hyperglycemia, which you can treat supportively. And if you've gotten nothing else from neonatal sepsis, just remembering the most important thing is that you just want to give antibiotics within the first 15 minutes of diagnosing sepsis. And that's like really important, not to delay antibiotics. And if you can't get IV access, then you just want to give it IM. And so in terms of antibiotics, the current antibiotics for neonates are D-pen, pen, and cefotaxime. I think it changed last year in the guidelines. And then your next priority would be things like fluid resuscitation and IV adrenaline. Okay, so I have a question about what I said regarding GBS. So in terms of risk factors, so basically GBS in the urine is a risk factor for GBS infection in the neonate if they have GBS in the urine in the current pregnancy, if that makes sense. And yeah, I'll just come back to questions again later as well, just in view of time. And yeah, so just management wise, literally just knowing that you just want to give antibiotics, everything else is supportive. And then we'll move on to neonatal jaundice, because it's a really huge topic, and it's probably the most important topic in this lecture. And it's very foreseeable as well. And so we'll start with a couple of questions. So a full-term infant is noted to be jaundiced at birth. His bilirubin is elevated at 205 with a conjugated fraction of 152. So that's 75% conjugated. On examination, he has hepatosplenomegaly and a widespread petechial rash. What do we think it is? Perfect. I'll just give everyone else a couple of seconds to think about it. Yep. Beautiful. So all of you guys are getting the right answer. So it's congenital CMV, and we'll talk about why. And basically with the hepatosplenomegaly and the petechial rash, it's the buzzword for CMV or varicella. And then for 24 hours, you want to think about sepsis. And torch infections is one of them. And then a 6-week-old baby is born with jaundice. A 6-week-old baby born at term presents with jaundice at 6 weeks. Her bilirubin is elevated with a conjugated fraction of 195. Her stools are really pale and she has dark urine. An ultrasound of her liver reveals non-dilated intrahepatic bile ducts and a small irregular gallbladder. So again, very buzzwordy. Yeah, perfect. So this is biliary atresia. And then, oh yeah, that's a sensitive question. So why is jaundice important? I guess we'll start with that. So basically you have that whole like progression from bilirubin to connectors, and connectors is basically when you have so much unconjugated bilirubin that goes into your brain and causes encephalopathy. And that's something that really, it can be really bad for the baby, and that's why we want to treat jaundice quite quickly. And so in terms of neonatal jaundice, it's obviously, as we all know, best to know it in terms of a timeline. So you have less than 24 hours, which is always pathological, 2 days to 2 weeks, which is usually physiological, and more than 2 weeks, which is often pathological, but can be benign, and it's known as prolonged jaundice. So, and then also unconjugated is basically when 90% of the total bilirubin is unconjugated. But as long as you have 10% of the total bilirubin that's conjugated, that's known as conjugated jaundice. In terms of causes, so hemolytic disorders can cause jaundice at any point in the timeline. And then in terms of less than 24 hours, you're going to think of sepsis. And then 2 days to 2 weeks, you want to think about these causes, and we'll go through them in detail as well. And then more than 2 weeks, you want to think about these causes. And something to flag is that sepsis and hypothyroidism can basically be conjugated or unconjugated. And everything else is either conjugated mainly in the first 2 weeks, and then more than 2 weeks, you're really thinking about, so, unconjugated in the first 2 weeks, and then more than 2 weeks, you're thinking about the conjugated causes. And then, so we'll go through the individual differentials. So less than 24 hours is always pathological, and you want to think about the rule of two. So essentially, you have two main causes, hemolysis and sepsis. And then within hemolysis, you have two subtypes. So you have extrinsic and intrinsic. And within each one, again, you have two differentials. So ABO and rhesus incompatibility, I won't be going through it in detail because Evan is going to go through it in his hematology lecture. But basically anything to do with mom is extrinsic. And then intrinsic, you want to think about hereditary spherocytosis as well as G6PD, which as we know is about alfalfa beans. And then you think about sepsis, which again, you have two types. So early onset sepsis, which we've just gone through, as well as torch infections. And we have a lovely summary sheet on torch infections because I won't be going through it today. And in terms of investigations, you basically want to do it based on what you think it is. And in each point in the timeline, you have a different set of investigations. So for all babies with jaundice, you want to do an FBE, SBR, which is serum bilirubin, and Coombs test. And then you can do a hemolytic screen or a septic screen, which we've just gone through, depending on what you think it is. And again, I'm not going to go through the hemolytic screen in too much detail because Evan's going to go through it. And then we think about 2 days to 2 weeks, which is usually physiological. So physiological jaundice, again, I know Anisha talked about humorous hacks, and I think that's a really good podcast for jaundice as well. And they went through it really well, and that kind of lent it in Y4C as well. But essentially, physiological jaundice typically peaks at day 3 and resolves by itself in about 2 weeks. And the reason it's really common, so it happens in literally like 1 in 3 babies, is due to the fact that they have a shorter fetal red blood cell lifespan. So when a baby is born, their fetal red blood cells start to die off, and therefore you get jaundice. And then also hepatic and gut immaturity, which prevents like the breakdown and excretion of your bilirubin. And then you have breast milk and breastfeeding jaundice, which I personally got quite confused about, but it's basically in the name. So breast milk jaundice is due to the milk, which there's this substance in the milk that basically causes I think it prevents or basically causes more bilirubin to build up, so a bit of a typo there. And then breastfeeding jaundice is basically due to insufficient intake, so it's mainly due to the behavior of feeding that causes dehydration. And with dehydration, you get decreased gut motility and therefore decreased bilirubin excretion. And then you have hemolysis, and this time you want to think about bruising. So all the birth injuries that we've just gone through can cause jaundice as well. And then sepsis, but this time you want to think about late onset sepsis, so all your staph infections, and then NICU admission. And then polycythemia, all your ONG conditions that you've learned about that can cause polycythemia, like GDM, IUGR, and TTS. And then lastly, your inherited disorders of conjugation, which basically you have deficiency of a certain enzyme that's required for bilirubin breakdown. So, we all know our Gilbert syndrome as well as Crigler-Najjar syndrome. And in terms of investigation, so again, all babies have to have FBE, serum bilirubin, and Coombs test. And then if it's breastfeeding jaundice, we want to do an electrolyte check just to make sure that they're okay. And then you also can do a hemolytic screen and a septic screen if you're worried about that. Yeah, we're not sponsored by Humantex. In terms of prolonged jaundice, again, hemolysis, breast milk jaundice, and congenital hypothyroidism. And the most common cause in this point is actually breast milk jaundice. But in terms of congenital hypothyroidism, similar to an adult, your birthhood would be a baby with quite coarse faces. As you can see, it kind of just looks quite coarse. And then they have dry skin, hypotonia, and constipation. And then in terms of your conjugated causes, so this is where like the money is in terms of all your births. So firstly, you have biliary atresia, and again, due to absence of the gallbladder or like hyperplasia of the gallbladder, and a buzzword would be that, but as well as that, your Alagille syndrome is another buzzword because it's part of the triad. And then you have your management, which is Kasai procedure, which leaves a Mercedes-Benz scar, which is another buzzword. And you can see in the liver ultrasound that you basically can't see the gallbladder and it looks quite empty, and therefore that's biliary atresia. And then comparing that with choledochal cyst. So again, this is just in the name, cystic dilation of the biliary system. And then in the ultrasound, you get dilated ducts instead. And because these two are obstructive causes, you can also get pill stools. And all your conjugated causes cause dark urine. And in terms of other causes of conjugated jaundice, so you have neonatal hepatitis, mainly vertical, and then your metabolic disorders as well, like galactosemia and fructose intolerance. And based on all of these causes, your investigations, this time you want to do a thyroid function test as well. And then your conjugated jaundice screen, basically want to screen for everything. So liver function test, abdominal ultrasound, coags, as well as viral serology and metabolic screen. And then we'll move on to your management of jaundice, which is also really important to know because it can basically come out for like a counseling station for a mom who has just been diagnosed with jaundice. Sorry, I literally have a bug like floating down like my flowers. I'm just gonna clear that. It's really gross. It's like a little worm. So assessment of severity. Yeah, so you want to plot the serum bilirubin on the chart, and we are very familiar with this chart. And basically, based on the gestational age, you basically want to plot the serum bilirubin. And if you're above the phototherapy line, give them phototherapy. If they're above the exchange transfusion line, give them exchange transfusion. And then you want to treat the underlying cause. Sorry. Okay, and you want to treat the underlying cause. So if they're septic, obviously giving them antibiotics in the first 15 minutes. If they're hemolytic or hypothyroid, then you want to escalate that. And then dehydration, referring them to a maternal and child health nurse. Obviously, any of the obstructive causes need a surgical review. And then we move on to phototherapy, which is really important. So it's this little picture here. So you want to explain how phototherapy works really briefly. So it's basically blue light that breaks down bilirubin into a water-soluble state, excreted in the urine and feces. And you can't use a transcutaneous bilirubinometer when they commence phototherapy. And the reason for that is phototherapy basically launches the skin, and so it becomes very inaccurate to use the transcutaneous monitor. Instead, you want to do a serum bilirubin every 6 hours. And then you can also talk a little bit about like a Billy blanket versus the light. So Billy blanket is typically in less severe cases, whereas the lights generally more severe and generally require maternal separation in the special care nursery. And then side effects are really important as well. So retinal damage, basically, you want to think about like baby getting a suntan. So you can damage your eyes. You can also get like tan, like literally bronzing. And this is basically if you're conjugated jaundice, so like biliary atresia, you can get bronzing, so bronze baby syndrome, as well as diarrhea, maternal separation, and dehydration. And then the last point, not very important and not very common, but basically after cessation of the phototherapy, you can get a rebound where you need to reinitiate phototherapy. But that's not a reason to delay their discharge as well. And then in terms of exchange transfusion, so this is when it's really severe, typically with rhesus disease, which is really severe and can escalate really quickly. And essentially you just remove the blood and replace it with donated blood, and you remove the bilirubin. And the main side effect to counsel about is obviously the fact that it's very invasive, so it can be a cause for mortality as well. And then you have your other side effects. So that was jaundice. Hopefully that made sense. And otherwise, you can come back to these slides. And I don't have any questions about it, so I'm just going to move on to the last two topics with ample time, thankfully. So prematurity is another station, like another possible OSCE counseling station. And the main things you need to know about prematurity are your risk factors as well as your complications. And you don't have to know it in like massive detail, just know it just enough so you can just like give an overview if you're asked to do a counseling station. So again, coming back to the birth weight and gestation rate definitions. Don't really need to know these, but the main thing I want to explain is chronological versus corrected age, because I got quite stuck on it when I was learning it. So chronological age is basically the legal age of an infant. So if they're born 2 weeks ago, they're chronologically 2 weeks old. Corrected age basically takes into account how many weeks they're born preterm. And the number of weeks they're born preterm is basically calculated with 40, which we assume to be full term, minus the number of weeks they were born. So for example, if a baby is born at 32 weeks gestation, we want to take 40 minus 32. And so we want to, so that's 8, and we want to take their chronological age minus 8 anytime that they are like calculated, if that makes sense. So I think I explained that really badly, but essentially corrected age is really important for their developmental milestones. So with preterm infants, it's really important to do that with their corrected age within the first 2 years of life instead of the chronological age. And then risk factors wise, it's pretty self-explanatory, but I'll just highlight the most important ones. So in terms of maternal risk factors, obviously a previous preterm birth, but as well as like a cervical insufficiency. So if a mom had like a positive cervical screening test and they required like a biopsy or like a cone procedure, then that's a risk factor for preterm birth as well. And then if they're smoking, as we all know, smoking like decreases like vascular sufficiency and therefore placental sufficiency. And then in terms of fetal and uterine causes, anything that causes stretching of the uterus can trigger labor. So you're thinking about things like a big baby, twins, a lot of fluid, and then meconium, as well as anything that causes bleeding, can also irritate the uterus and therefore trigger labor early. Is number of weeks preterm, number of weeks before 37. Yeah, so I guess with corrected age, preterm is 37, but with corrected age, you calculate that like 40 minus the number of weeks they're born preterm rather than 37. So that's something I got quite confused with as well. So 37 weeks is preterm, but corrected age, you use 40, if that makes sense. And then we'll go through the complications. So the way I think about complications is short term versus long term, and then in terms of like all the different systems. So I'm not going to go through everything because there's a lot, but I'll just go through the most important ones. So Anisha has just gone through PGA in great detail, so I'm not going to touch too much on that, except that just more an FYI thing. Mainly they're using Panadol or like paracetamol now in terms of management, especially like in MCH. So that's really interesting. But for your exams in a medicine, respiratory wise, so apnea of prematurity, basically a preemie has like episodes of apnea where they just stop breathing, and you just want to give them caffeine because it's a stimulant and it's going to help them to stimulate breathing. And then pneumothorax is basically a complication of ventilation that we mostly give for respiratory distress syndrome, and the ventilation, depending on how high the pressures are, can actually cause the pneumothorax as well. GIT, you get neck, which Ben will go through, so I'm not going to go through that in too much detail, but immature liver and pancreas can basically result in jaundice or hypo and hyperglycemia. And then neurological wise, the two important neurological complications. And it's basically in the name in terms of how to differentiate them. And you basically want to do a CT or MRI to pick that up. And then renal-wise, you can get electrolyte disturbances because of renal immaturity. And then the last thing I'll go through is hypothermia, which is really important because when a baby is born, you basically want to put them in a bag to keep them warm. And then obviously in the NICU and stuff, you see all the babies in incubators as well. I'm getting a lot of questions. I've noticed some hospitals give vitamin D to premature infants. Do you know why? Oh, I actually don't know why. Yeah, I don't know why. I'll get back to you on that. Can you have a negative age with corrected age? Yeah, I suppose you can. And you just basically want to get them to reach like age 0 and stuff. And then corrected age is also really important for the next slide. So long-term complications. So 2 main important things to know would be retinopathy of prematurity or RP and bronchopulmonary dysplasia. So RP is basically due to in the NICU, we give everyone we give most babies oxygen in the NICU because they have like targets they have to meet in the NICU. And because they're in the NICU for a really long time, they get a lot of oxygen. And that oxygen can basically cause like free radicals and can cause retinopathy in the eye. And then respiratory wise, we have bronchopulmonary dysplasia, so chronic lung disease in the newborn, which is basically defined as a need for oxygen at 36 weeks corrected age. And that, again, due to like a whole bunch of reasons, I'm not going to go through it because it's very multifactorial, but lung immaturity as well as ventilation-induced injury. And then you have your 2 things that you most commonly think about, which is neurodevelopmental delay and growth. And again, with growth charts, so this is an example I had here. So if an infant is born at 32 weeks, subtract 8 weeks because 40 minus 32. So at 3 months, the corrected age is 1 month. At 5 months, the corrected age is 3 months, and so on and so forth. Great. Perfect. Then Chelsea has just saved me. So primates can get osteopenia or prematurity. Common to give vitamin D because of that. And then we'll end with infectious diseases. So really, I'm only going to go through childhood viral illnesses. And it's all based in buzzwords. So just a couple of questions. So a 3-year-old boy presents with a 2-day history of fever, malaise, and reduced appetite. Today, he has developed sores on his hands and ulcers on his mouth. Yeah, I wonder what it could be. Perfect. So it's just hand, foot, and mouth disease. A 4-year-old boy presents with a 2-day history of fever and generalized joint pain. On examination, he has bright red cheeks. Yeah, so your slap cheek disease. And then a 3-year-old boy presents with a 4-day history of fever, widespread rash, and conjunctivitis. He's noted to have white spots on his soft palate. Yeah, you guys are so quick, just on the buzzwords. And then a 2-year-old girl presents with a 3-day history of high fever. The fever is now resolved, but she now has a rash on her trunk. And the buzzword here is a really high fever, as well as the fact that she's 2. Yeah. So I sort of whisked through that, but you guys were really quick. But essentially, yeah, I just need to know these couple of diseases. I'm just gonna move my thing. Okay, so viruses, you just have to know it. Like, you can't really guess it, but you just have to know it. In terms of risk factors, it's mainly age that's the risk factor. And something I want to highlight is that measles and chickenpox have immunizations for it. So the risk factor would be just kids who are not immunized. And then Rhodiola infantum, it's literally infantum. So you want to think about infants, so 6 months to 2 years, and the other 2 is just 3 to 4 years old because they're in preschool and like you know, just touching each other and spreading germs. And then in terms of presentation, so this is when all your buzzwords come in. You don't have to know too much about like incubation period, prodrome, things like that. But measles, you basically have your 3 C's or your 4 C's if you want to take colic as another C. So cough, conjunctivitis, and coryza, as well as these little white spots on the palate, which is known as your colic spots. And you have a rash that basically can go anywhere in the body, and it begins from your ear and then spreads all the way down. And then Rhodiola infantum, you get a similar rash, but it's mainly on the trunk. But the buzzword is febrile convulsions due to the fact that they have a really, really high fever. And then chickenpox, you basically have your vesicular rash and it's really itchy. flap cheek disease or erythema infectiosum, basically you have flap cheeks. And important thing is when they have flap cheeks, they're not actually infectious anymore. So you get a lot of kids just running around in preschool with flap cheeks. And then the last one, I'm just going to move my camera again, is your hand, foot, and mouth disease, which is literally just blisters and ulcers in your hand, foot, and mouth. And then investigations-wise, all of them are clinical diagnosis. And in terms of management, because it's viral, all of them are supportive, except for the fact that, I guess, in terms of ONG counseling, you want to give ZIG if they're pregnant or immunocompromised. And yeah. And then for hand, foot, and mouth, if they're unable to eat because of their ulcers in the mouth, then you want to consider admission for like TPN or an NGT, just to help with that. Cool, and that was it. I think I did that within time. So if you guys have any questions, feel free to pop them in the chat. Feel free to email me anything. I'm happy to answer, even if it's not related to these topics. And I will stop my screen share. You're welcome.
Awesome. Thanks. That was really good. As Liz said, I might have frozen. Am I frozen? Okay. As Liz said, if you have any questions, feel free to message in the chat or on the Slido. But we now have a little morning break. So we have a break until 10:55. So keep this Zoom on. Another reminder to have some cool Zoom backgrounds if you want to win a $50 prize. Everyone else who doesn't have their video on, you won't be in the running for that $50. So